morning. My name is Doug Smith, and I work for an organization called Martins Point Healthcare in Portland, Maine. I work on the delivery side of the business. Our organization is both a provider of healthcare as well as an insurer of healthcare. Today we're going to talk about using technology to empower the consumer, and it's one of several sessions that are here at the FiRe conference this year devoted to healthcare. I'm joined today on my left, your right, by Peter Neupert, the Corporate VP for Health Solutions for Microsoft, and Dr. Roy Schoenberg, the CEO of American Well Systems. The profiles are in the book and are quite extensive. I think you'll see if you look at their profiles that they're serial entrepreneurs, have been in a number of different ventures over the years, and can certainly contribute and speak on this technology and how it can be used to empower consumers. Given the breadth of our subject, I felt it was important to kind of establish some guardrails for our conversation, because it's very easy to get into talks about politics and relationships and the financing, some of which are covered in other sessions. And I know from some of the informal conversations I've had both with Peter and Roy, we've already gone into those deep wells of conversation. But in light of the previous session, I thought it'd be helpful to give a little bit of a framework for what's going on in the United States, just a minute or two about it, to give you some sense of the scale of the issues we're trying to address. First, the healthcare in the United States is topping $2 trillion of expenditure per year and has been increasing for 20 to 30 years, almost unfailingly at double the rate of the CPI. This is unsustainable. You don't even have to get beyond Economics 101 to realize we can't, as a nation, continue to do this, as was brought up in the previous session. We've tried a number of things to try and manage the costs and manage the care. A fee-for-service medicine, which was reimbursed on a per volume, per visit kind of basis, has turned into kind of a monster where visits have doubled. A physician seeing 14 patients in the 1970s and 80s has turned into a physician seeing 30 patients a day, and obviously the amount of time they spend with the patients has been reduced quite dramatically. We took a swing in this country at managing care and cost under the framework of managed care. That was something that was, I think, well-intentioned, and I certainly was part of that movement in the 70s, 80s, and 90s, but it got a bad name, and it was shown up in various news programs as expressions like "hell no HMO." It turned into a rationing kind of thing, is the way people looked at it. We come to where we are today, where I think, in summary, people in this country aren't really happy with the quality of care they're getting, the health outcomes, and my gosh, it's costing them a lot of money. Some people have opted out of the system to the tune of 48 million in this country out of about 300 million, and have gone the uninsured to uninsurable route, and are being supported in their health care needs when they have them by subsidies from the federal government or by the private pay in the sense of cost shifting in hospitals and other places. Certainly, one way to address this problem of cost and care and try and put the consumers back in the driver's seat, getting what they need, when they need it, and getting a better outcome, is by using technology. And I think virtually everybody in this room has looked at technology as a way to solve some big problems in our world today. And so today we come back to this notion of how can we use technology better to try and solve this problem of healthcare, to empower consumers, to put them kind of back in the driver's seat. So without any further ado, let me turn to the panelists today. And I would look to Peter in that Roy has already had a chance to talk about his company. Peter, could you tell us something about your products and how they might address some of these issues of cost and care?
Well, first I want to remark on some of the comments that Bill mentioned. I think I agree with almost everything he said. We're building a global set of products to meet not only the needs in America, but also the needs in the emerging markets. We have two main initiatives, one on the enterprise side, one on the consumer side. Since Bill brought up what's going on in the third world, let me talk a little bit about the enterprise initiatives. We acquired some software from a hospital in Bangkok, Thailand. I was there 2 weeks ago. And they demonstrate how you can use information technology and leadership and management to really deliver better quality care at dramatically lower costs with completely better service and benefit outcomes. They see 1.2 million patients a year. Over half of them come from outside of Thailand to go there to get the quality of their services. And it's just a phenomenal experience, quite unlike the kinds of experiences we have in US hospitals. we thought that information technology could make a dramatic difference in how they process, how they provide care, how they manage their workflows, and we think we can bring some of that. I think one of the points that Bill made that I wanted to reiterate is we spend in this country probably $60 to $70 billion a year trying to find new therapeutics. We spend less than $1 billion a year throughout the system trying to figure out how to do a better job delivering the care that we need. That's almost the opposite of what most industries do when you think about sort of basic research and actually applied engineering. And there's an increasing understanding that we need to do more applied engineering, systems engineering, to the delivery of medicine to try to do both get better results and better cost structures. When we looked at it and tried to think about how could software really make a difference, you have to understand that ultimately the health system in this country isn't really a system at all. It's an ecosystem of a lot of competing interests, a lot of competing perspectives that don't have a shared or common infrastructure. There's a variety of different people that are trying, and institutions that are trying to solve this problem of not a shared infrastructure. Frequently they talk about it at the institutional level. I don't know if you've participated in a RIO, a Regional Health Information Exchange, or the National Health Information Network, all these sort of activities that I don't think are really sustainable on the current economic grounds. And so we looked at it and said, how can we use the consumer as an agent of change? If we can't get institutions because of competing interests, how can we empower the consumer and get them to be an agent of change to be able to build a common infrastructure? And so we built a product called Health Vault, which is a shared data repository owned and controlled by consumers, the objective of which is to enable and to connect all of the source data providers, whether it be physicians or hospitals or labs or pharmacies, as a means of empowering the patient to have more, or a citizen to have more capability, more information, more understanding. Now, I agree with what Roy said earlier, which is I still can't act. At the end of the day, somebody wants to act, and we need to be able to bring that transaction piece of it as well. But we wanted to start with building this sort of common, data-driven foundation against which now we could perhaps do a better job with delivery of and the transaction of, and to move care to the right point and place. In order to move care to the right low-cost place, you need to have the right data set in order to be able to do that. So that's what we're focused on.
Thank you, Peter. Roy, if there were some outtakes from your hotspot, what would they be? Some other things you might want to add back in?
Well, I think it kind of ties very well to what Peter said, and I emphatically agree with literally every statement that was made here. I think the system is fundamentally broken. I think everybody kind of knows that at that point. It is so broken that now there is a movement in healthcare technology that is called Health 2.0 because it recognizes that Health 1.0 is so broken we actually have to do a paradigm shift to fix it. And there has been over the years so much effort to try and fix it from the top down. So health plans have been trying to create cookbook medicine, and I think one of the reasons why people were upset with the HMOs was just because of that. They were telling providers how to do their job. And providers and delivery networks have been trying to become more efficient in different ways by things like DRGs and so on. Doesn't matter what the acronyms are. But we're faced with such a fundamental problem that really, if you look at other industries where transformation happened, the biggest force in the industry is the demand, not the supply. And the demand in healthcare are consumers, are not the hospitals or the HMOs. And we have traditionally, I think, overlooked consumers. Consumers are, if we talk about consumer empowerment, it's because they're so unempowered today. They don't know how to seek care. They don't know where to go. They can't really identify whether one care offering is better than the other and how much it needs to cost. They're so far behind as a buying power that the changes that we see now about consumer empowerment are going to actually have a very radical impact on the transformation of healthcare. And there are, for a market to really embrace consumers, there needs to be some fundamentals in place. First of all, a consumer has to have the knowledge of what they need to buy. They need to have a place to buy it. They need to have a currency to do it. And there need to be some kind of metrics to understand whether what they've bought is actually working for them. And really, if we look at the fundamental layer of that evolution, essentially products, the PHRs, the portable health record, things like Health Vault, are really so crucial because, the only thing that connects the care points of any one individual consumer when they go to see a cardiologist, an endocrinologist, and a dermatologist, and so on and so forth, the only thing that really connects all these different dots is the consumer. It's not the delivery network or anything else. And the only thing that will follow a consumer from a buying power standpoint is their medical information. The transformation of PHRs allows consumers to become effective buyers. And when they become a buyer, they're going to completely transform the industry.
There's some great points there, Roy. I think, and Peter, one of the things that really connects for me is that for literally decades now, I've seen these diagrams of the healthcare system, and at the center, the bullseye is the provider. And I think in our organization, I hope it's a trend across the country, that what you see in the center is the consumer. They are the customer. They are the one that's the most important. But it does, some of the points you raised, Roy, do kind of spark some other thoughts, which is, how do you measure quality? How do you measure cost? Well, I know what cost is. I can reach in my pocket and see what that is for by and large. But how do I relate that to quality and some kind of value proposition? As an example, in the product that your company offers, if I understand the model correctly, they're going to, a patient is going to connect with a provider. And I use this as an example because it's true when you're signing onto a blog or any other place. How do you know that the person you're connecting with is going to give you a positive experience, a valuable experience, deliver quality care? So as an example, how would a consumer assess the quality of the physician? I'll let you paint it as you wish.
I think that's a very, very difficult question, and from a commercial standpoint, I can tell you that we have kind of elegantly avoided that question because the perception of quality from a consumer standpoint, specifically about caring essentially their health care, is so confounded. It has so many different aspects. Some consumers will tell you that they don't care if their physician is the most obnoxious person for as long as they treat them well. And then other consumers will simply walk away from a physician who is, too paternalistic or is not answering their questions. The only thing that I think works for us is that when you bring these kind of consumer insights about physicians to a very, very large scale, so if you have literally hundreds of consumers who can advocate about their experience with an individual physician, their level of satisfaction overall over time from that physician will remove the noise from the equation. And if you are, if there are 100 patients that said that their experience with this physician was great, the only thing we're saying is that probably the 101st is also going to benefit from that kind of experience. Whether that is truly because they have expert knowledge or expert service, it's unclear, but it is consumer satisfaction that's going to drive quality definition.
So that certainly is one of the pervasive challenges, and in healthcare, quality is like the holy grail. You can get 6 people in the room and they'll define it different ways. I think if you folks have been subjected to or part of surveys for hospital experiences or outpatient clinics, you probably can remember what some of the survey items are. They're typically, how convenient was the parking? Was your appointment on time? Was the registration clerk polite? It doesn't really get into what, at least I would like to think, is at the heart of quality, which was I better as a result of that experience. So.
I think both parts are important. What shocked me is sort of being the new kid in thinking about some of the health problems is it's not really just the consumer that should be measuring quality. And that health systems in general, while they are trying to do better, compared to other industries, do a terrible job in measuring most things. And if, as I heard Bill talk a little bit earlier, you could talk about the metrics, both volume, quality, error rates, all those other kinds of things. Now we could start to have objective metrics as well as service-oriented metrics about quality. But science, humans are complex. They don't just present with one thing, they often come in a bundle. And how one determines what real quality is over time is a challenging problem. If we don't start measuring, if we don't start building systems, if we don't start trying to build an evidence base to accomplish that. Now, in some areas, they can do it really reasonable. Procedural-oriented things, you can have pretty good quality outcomes. Disease-oriented things where you have to measure it over time. And oh, by the way, the outcome is a function not only of the care you get, but of how well you take to the plan you're supposed to be on.
Compliance.
Right?
Yeah.
And so there's these set of interactions where it makes it complicated, but that doesn't mean we can't get better at approximating it.
Yes.
And moving on a path. As Bill indicated, the challenge, if you go buy a car, you're interested in what the quality rating is because you're going to suffer the consequences. The consequences of not complying, not filling a tire or not changing the oil or all those kinds of things, for our health system anyway, is put on to everybody else. And we have to figure out a way to where we get the feedback mechanisms to work better so that the individuals can participate, and their providers. That you have to have both of those feedback mechanisms working to where you're going to end up in a common goal. They're not always aligned goals at the moment.
Yes, and I agree wholeheartedly, Peter. We typically categorize it into service quality and clinical quality, and either one is a dissatisfier if it's not met. We seem to be doing okay on the service side, my quips aside. It's on the clinical side where we're certainly challenged. Well, it seems like we're in frightful agreement here. Let's see if we can get a little more contentious or identify some of the barriers to adopting of the technologies that are out there. We touched on one about quality measures in an internet type of experience for a visit. Peter, it seems to me one of the challenges of adoptions of PHRs is the level of, for want of a better term, digitized healthcare information out there. What I mean to put a fine point on it is, at least in the state of Maine and most of New England, there's only about 75% of the physicians who actually have electronic health records. So how would information get into a personal health record if the patient was going to a physician who didn't have something like that, electronic health record?
And you said 70 to 75% have electronic medical records.
Oh, do not have.
Do not have, yeah. I just wanted to clarify. It would have been a shockingly
It would have been
positive
a wonderful
statistic.
reality.
Actually, while connecting is a problem, the fact of the matter is, my observation or belief is that huge amounts of the highly important and perhaps most important information is available electronically. The two data sets that most physicians want in an emergency in particular, and perhaps in starting a diagnosis, are medication lists and the most recent lab or x-ray. Those data sets do exist electronically. They may not exist electronically in the physician's office, but they do exist electronically in the infrastructure. And we are hard at work at trying to make those accessible to the consumer. That is a beginning point. It's not an end point. And I want to reiterate, Health Vault is not designed to be just a personal health record. We don't yet need another silo. There are silos at the pharmacy, there's silos at the labs, there's silos at the physicians. We're not trying to create another silo. And the data by itself doesn't mean anything. It's about what does it mean to me and what can I do with it, which is why Health Vault has a programming interface on top of it. Enables that to be able to create knowledge, to be able to share it, to arbitrarily share it with family members or caregivers, because when somebody's really sick, there's generally a group of folks that are concerned with the care, and they all need that same sort of data management platform. And those are important differences from prior personal health records. And so I'm confident, while there are many barriers to getting started, that over the next 5 years, those key data elements will get connected.
It seems like one of the undercurrents that has become somewhat of a tsunami is this cost thing. How would, as an example, Roy, to turn to you for a moment, how would you characterize your product as having an impact on the absolute cost of care? Are there some examples you can spin out?
Well, I think we are at the early stage of deploying this into the market, so I'll be happy to come back, in 2 years and give you more insight about this. But one thing that we absolutely know is that if you follow health plans, who are, in reality, they're the driving force of healthcare in this country. They are the ones paying for the majority of it. Health plans have been spending hundreds of millions of dollars, and that's an understatement, I think, over the last couple of years to try and shift care from very expensive cost settings to less expensive cost settings. I'm not going to, there's like a fruit salad of things like DMCM, utilization management, care management, and these are different programs that cost a lot of money for health plans every year to try and go around patients, look at their care, by the way, by looking at digitized information, and try to intervene to make sure that those patients are being cared for at the lowest level care point that is sufficient to give them care. Usually it is all about making sure that patients don't stay in the hospital too long, that they can be cared for in outpatient clinics, they can be cared for in the community practice, and so on. What we are bringing into the mix is really a capability that's based on technology to expand dramatically the scope of care that you can give to any one patient at the very far end of the spectrum, at the least expensive cost setting, which is the patient's homes. Now, that doesn't necessarily mean that you're going to shift everything in there. The reality is that there are things that you can do in a physician practice that you can do in the ER, in the emergency room, that you can't do in a physician practice, but both really have a place in caring for the patient. Because of the fact that you can bring the healthcare system through this, essentially, infrastructure into the least expensive cost setting, you are radically changing the notion of how much involved a patient can actually be in their care, simply because of the effect of convenience, and don't knock convenience, it's a big deal in 2008. It is the fact that you can get them to be more compliant, which is what we discussed just now, simply because they have the guidance from the disciplines that they're looking to get guidance from. They hear a cardiologist telling them that they need to take a certain drug for their condition. But more importantly, as plans are now shifting the payment that consumers have to make going up, there's we talked about it this morning, that people have to pay more for the care that they have. Having the ability to get an understanding of how you need to consume services before having to leave your home and hit the healthcare system, which is exuberantly expensive, essentially creating somewhat of like a GPS system for navigation into the healthcare maze, really equips consumer with a better understanding of where to consume and what to consume. That has a very, very significant impact on utilization of services. And that is why health plans are kind of jumping up and down when we're introducing those kind of systems.
I'd like to jump on a couple of things. People throwing lots of numbers around, and I think there are a fair set of statistics today where people acknowledge that 70% of the costs, 70%, that's a big number, 70% of the costs come from 6 chronic conditions. Many of those chronic conditions have things that chronic conditions mean you live with them for a long time, and it's how well you do managing those things. Today, our system in a fee-for-service basis is completely set up not to do an effective job, a cost-effective job of helping people deal with those chronic conditions. We think one of the attributes of Health 2.0 is to enable user-generated data. One of the attributes of Health Vault is to enable blood pressure cuffs and glucometers and all the things that help people understand the state of their disease, to make it easy to get that data, which often isn't captured in any meaningful form, into a shared data store that could be shared with their physician. That now I have a lot of entry points. I think Larry talked about, hey, you need to intervene a lot earlier. You need to be able to predict. Well, you got to have that data set to be able to do that, to avoid the condition that, oh, I end up in the emergency room because I forgot to take my pill or because I got out of whack. There's generally signal available to intervene way before you show up in the emergency room. So you got to change that paradigm. Well, we need to change it with the technology, but we also need to change it on the business model side. And whether we're set up to do that or not, I don't know. But let me leave you with one last data point, and that is The Commonwealth Fund, who did this recent study in preparation for going forward, said the single condition, the single thing they could do to help lower the cost curve is to deal with obesity. Obesity isn't necessarily a care delivery problem. It's an incentive and behavior management problem, right? And there's completely different sets of things that need to get done to help deal with that. But that's the single biggest thing that we can do to control healthcare costs going forward, is to deal with the crisis of obesity.
And start early.
And start early, yeah.
With teenagers.
Absolutely. Yeah.
Yeah, what we have found in some of our research is frequent touches with chronic care conditions is one of the keys. And it doesn't have to be a doctor. And unfortunately, a lot of what we do in healthcare today, you got to see the doctor because that's the way they get paid. So I think we're kind of shooting ourselves in the foot, which is a bit surprising. But what surprises me even more is how quick we are to reload. Well, we should probably leave some time here for questions so we could bring up the lights. I know there's microphones circulating around.
There's one in the back.
Yes.
I could barely see it. Yeah.
Hello, my name is Jim Peoples. I'm with Booz Allen. Earlier in the conference at the beginning, Mark suggested that all the problems are exponential and there's no such thing as linear. So if healthcare is taking off at an exponential rate, what are we doing, or how does your products fit into that scenario? Where are you going to catch it on the curve?
Yeah, I'm not sure how to respond to that part of the question. In our context is we're trying to create a viral activity around consumer demand for the ability to interact with their physician in ways that they interact with their bank or their travel service or what have you. And we believe that you don't have to get them one at a time, that physicians and the connection points, that will have the benefit of the network effects once we get started. The hard part is how to get started and create the demand and the belief that if you're not connected, you won't be able to deliver either the quality of service or the kind of service or be the kind of leader that you wanted to be in the game, in the business, whether you're a physician or a pharmacy or another source data, what we would call a source data provider. I happen to see that kind of belief starting to happen, having built platforms before for Microsoft. You see that kind of momentum at the very beginning. It's all this noise that nobody else sees, and then it starts to build. I believe that's starting to happen, partly given the work we're doing and the fact that Google's playing sort of the same game, the fact that there's entrepreneurs all around that say, hey, we need to jump on connectedness and connectivity and communications to be able to change the game, that maybe, just maybe, as fragmented and as slow to change as our health system is, the institutions are starting to say, hey, we have to do something different, and with these kinds of players in the game, now's the time to get started. So maybe we can get on that exponential curve. I don't know.
I'd like to add one thing to Peter and kind of sharpen the spear, if you will. I think the viral activity and try and spread it out is kind of a broad strategy, but going after the high cost points, the chronic care conditions, those people who are in the last 4 or 5 years of their lives, and those people who are teenagers and have unhealthy habits because they're building in big costs in the future. My understanding from the statistics is this is the first generation that doesn't expect to outlive its parents. You know, the actual life expectancy is going down because of obesity, diabetes, and some other factors. So going after the potential costs of the youth because of unhealthy habits and going after the real cost of the aged are two potential areas to point the technologies and try and get kids engaged in games that get them interested in healthcare, whatever it takes, and get the older folks engaged, perhaps socially, if that's the way to do that, in their own healthcare.
Just want to, with the 30 seconds that we have left, just to try and answer your questions too. I think that pointed interventions are very, very important. But if you, as you said, this market is growing in its problems exponentially, the only solution that you can bring to the table that has worked in other industries is to expose healthcare to market forces, which is something that it has been notoriously uncomfortable doing. And if you do expose it to market forces, both from a pricing standpoint, transparency standpoint, and availability of service, which is fundamental, you have enough power to make a significant change. And I think it's going to take different components that have to kind of sync and align like stars to make that happen. But we are seeing this happen over the last 2 years, and I think that's very encouraging, in effect.
Well, our time is up. I'd like to thank Peter and Roy for joining us today and look forward to the rest of the conference.
Thank you.